Hello, this is Professor O'Connor again, and this is the sixth part in the series of your prep work for the acute respiratory disorders in children, and this is on otitis media. This is a photograph from your book, and on the left you are looking at the eardrum this is a normal ear, and these are all the different parts that are labeled. You don't need to know the different parts, but why I'm showing you this is that you can see that the actual eardrum itself is clear and there's no redness or swelling. Over here, the eardrum is opaque, and so that is something that you would want to look for. So, otitis media, the cause of it is unknown, but it is related to eustachian tube dysfunction. And as you saw earlier, the eustachian tubes in infants and young children are shorter and more horizontal. An upper respiratory infection often precedes the acute otitis media. And so pathophysiologically, they could have an allergic rhinitis, edematous eustachian tubes, airflow blocked, air trapped in the middle ear, which is reabsorbed and replaced by fluid from the lining, and that becomes a perfect median for pathogen growth. There is acute otitis media, which is commonly caused by viral pathogens and can resolve spontaneously. If it is caused by a bacterial pathogen, that would require antibiotics. There's otitis media with effusion, which occurs usually after an infection resolves. Fluid remains in the middle ear, and sometimes this can remain for several months. It also can occur because of the position of the eustachian tube, and lastly can occur because of a high number of upper respiratory infections in infants and young children. Complications from acute otitis media are hearing loss, expressive speech delay, tympanosclerosis, which is a scarring of the tympanic membrane, which usually has no effect on the hearing, a perforation of the tympanic membrane because of acute otitis media with resolution, or could be with chronic otitis media. Then there's chronic suppurative otitis media, where there's chronic drainage via perforation or tympanostomy tubes. There's acute mastoiditis, which is an infection of the mastoid process, and intracranial infections, including bacterial meningitis and abscesses, can occur. Diagnosis is made using an otoscope with a pneumatic attachment. There's an SGAR, which is a special gradient acoustic reflectometry, which measures the condition of the middle ear by introducing sound and measures the tympanic membrane. So there's acute otitis media, which is an acute onset, and there's marked redness of the membrane. There's recurrent acute otitis media, where there are repeated bouts of acute otitis media, and that is defined as 3 times in 6 months or 4 times in 12 months. And I have a YouTube clip on that, which will be hyperlinked. There is otitis media with effusion, which is OME, and that's fluid accumulation with no inflammation. And I have a YouTube clip which shows myringotomy and grommets, or tympanostomy tubes, being put into place. And the third type of otitis media is chronic otitis media, and this is when it occurs for 3 months and there is hearing loss. And I have a YouTube clip for chronic otitis media as well. So signs and symptoms of acute otitis media would be a fever, and you have to determine if it's under or over 39 degrees centigrade. The child could be complaining of ear pain, which is known as otalgia. They could be fussy or irritable, crying inconsolably, especially when lying down, batting at or tugging their ears, rolling head side to side, poor feeding or appetite, lethargy, night awakenings with crying or difficulty sleeping, fluid draining from the ear, vomiting, and or diarrhea. The physical exam and diagnostic testing for acute otitis media is the complaint of the ear pain on exam. The tympanic membrane may be dull or opaque and is bulging and or red. Sometimes its green or yellow purulence can be visible behind the eardrum. The pneumatic otoscope will show an immobile eardrum, and if the eardrum has perforated, drainage will be present in the ear canal. You want to palpate for cervical lymphadenopathy, and tympanometry is not useful in the diagnosis of acute otitis media. So what I have here is what the timeline is for treatment. So if a child is 6 months of age and the diagnosis certainty is either certain or possible diagnosis, treatment is antibiotics. From 6 months to 2 years, and there's a certainty of the diagnosis, treatment is antibiotics. If the child is 6 months to 2 years with severe illness, and it's possible that they have the diagnosis of acute otitis media, then the treatment is antibiotics. If the child is 6 months to 2 years of age with non-severe illness, and it's a possible diagnosis, then it's watchful waiting. We observe, and you watch and wait. Does the child become more sick, which means they then go down the pathway to get antibiotics. If the child is older than 2 years with severe illness and the diagnosis is certain, the child receives antibiotics. If the child is older than 2 years with non-severe illness, the diagnosis is certain, we observe. It's watchful waiting. And if the child is older than 2 years with possible diagnosis, we observe, watchful waiting. This you need to know, so make sure that you study it. Antibiotic therapy is treated first line with amoxicillin, and that it would be 80 to 90 milligrams per kilogram per day. The second line of antibiotic treatment is amoxicillin with clavulanate or cefuroxime. Azithromycin or Zithromax can be used, and cephalosporins such as cefninir, cefuroxime, and cefodoxime can all be used as well. So for nursing management, our goal is to manage pain. Analgesics like acetaminophen and ibuprofen are effective to manage mild to moderate pain, and there's an added benefit by reducing the fever. Narcotic analgesics may be indicated for severe pain. Application of heat or cool compresses can be used. Have the child lie on the affected side with heat or cool compress in place, and they can use numbing eardrops such as benzocaine or Aralgan, which may help reduce severe pain, and use that with the analgesics due to the short duration of effectiveness. So we want to educate the family, and if the treatment is watchful waiting or observation, we need to explain the rationale for that. And the rationale is that overuse of antibiotics for treating otitis media created bacteria that were becoming more and more resistant to the antibiotics that were available. And so now we only treat severe cases according to the plan that you just saw. And we want to ensure the family understands that they need to return for reevaluation if there's no improvement or if the child progresses to severe illness. If the treatment is antibiotics, explain the importance of completing the entire course. Many people stop giving the antibiotics after 48 hours because the child's condition has improved. And we need to explain the need to return for follow-up to ensure that there is a resolution of the acute otitis media. We want to prevent acute otitis media. So we know that breastfed infants have a lower incidence of acute otitis media, so encouraging parents to breastfeed their babies for the first 6 to 12 months is beneficial. We want to avoid excess exposure to others with upper respiratory infection symptoms. Avoid exposure to secondhand smoke. Encourage the parents to immunize the child with Prevnar and influenza vaccines. And also, chewing gum that contains xylitol, which is a sucrose substitute, may actually be protective for older children. Older children may chew this gum. Younger children may be given xylitol syrup. For OME, otitis media with effusion, the medical treatment is acetaminophen for pain and antibiotics only if it lasts more than 3 months. For chronic otitis media, they can do a tympanostomy, antibiotic eardrops, and if they also have a nasal obstruction, an adenoidectomy might be called for. So I have a picture here of otitis media with effusion, and you can see that it's kind of dull, and there is a collection of fluid behind the ear. So that is the effusion. There's a presence of fluid within the middle ear space without signs or symptoms of infection. It can occur independent of acute otitis media or after the infectious process of acute otitis media. The risk factors for OME include a passive exposure to secondhand smoke, absence of breastfeeding, frequent viral upper respiratory infections, allergies, a young age, male gender, and adenoid hypertrophy. Surgical treatment for OME is the myringotomy and tympanostomy tubes. And this is a picture from your textbook, and it shows you the myringotomy and tympanostomy. And they might do an adenoidectomy for recurrent OME. They can just do a tympanostomy to treat chronic otitis media, or they can do the adenoidectomy if it's chronic OM with nasal obstruction. Nursing assessment for OME is to obtain a health history, determine the extent of the symptoms. These children may actually appear asymptomatic. They may experience a popping sensation or fullness behind the eardrum, and explore for risk factors like the passive smoke exposure, absence of breastfeeding, frequent URIs, allergy, or recent history of AOM. Physical exam for OME is you need to use the otoscopic exam, which will reveal a dull, opaque tympanic membrane that may be white, gray, or bluish. And if it's not opaque, you can see a fluid level or air bubble behind the eardrum. The diagnostic testing, mobility may be absent or diminished with the pneumatic otoscope, and tympanometry can confirm the diagnosis of OME. For nursing management of OME, we want to educate the family. We want to teach them regarding the anatomical differences in children and about otitis media with effusion. Teach parents that antihistamines, decongestants, antibiotics, and corticosteroids have not been proven to aid in the resolution of OME. It usually resolves spontaneously. The child should be checked every 4 weeks, and the child should not be fed in the supine position, and the bottle should not be propped. We want to monitor for hearing loss. When OME persists, the primary concern is for hearing loss. Impaired hearing can cause significant language delay in developing, and they are at risk for severe speech, language, and learning problems. Chronic OME is the same as persistent OME of 3 months or longer and should be referred to a specialist for hearing evaluation. If they are not at risk for speech concerns, they should be reassessed every 3 to 6 months. We want to create effective communication with a child who has OME and a hearing loss. So to do this, we want to turn off music or the TV to eliminate background noise, position ourselves within 3 feet of the child before speaking, face the child when speaking, use visual cues, increase the volume of speech slightly, speak clearly, and request preferential classroom seating. For postoperative care of a child with tympanostomy tubes, we want to, the standard treatment is surgical insertion of the pressure equalizing tubes, or PE tubes, into the tympanic membrane. The tubes are going to stay in place for at least several months, and they generally fall out on their own. Usually it's done on an outpatient surgical procedure. Teach the parents to administer eardrops postoperatively. We have to avoid water entry into the ear canal, so they either wear earplugs in the bathtub or while swimming, and sometimes there's a special headband that can be used. PE tubes allow for adequate hearing and encourages speech development, but it does not prevent infection. And if infection occurs, PE tubes allow the infected fluid to drain. This is the end of part 6 and the end of all of the little videos. There are a couple of video clips from YouTube that I want you to view, and after that you need to go to the forum to participate in the discussion board. Be prepared that when you enter class, we will be doing 4 case studies. It will be as if you are in clinical. Once each group has presented their case study to the class, we will review the highlights of the material. I will have a summary handout for you posted on Moodle, and there is also a Prep U quiz that you can use to help you with this material. And thank you for participating actively in this unit.